Hello, everybody. Welcome to the Research into Practice webinar for July. My name is Emma Wilson. I am the Communications and Engagement Officer for Research and Innovation at Greater Manchester Mental Health NHS Foundation Trust. Thank you all for joining us today to hear about the findings from the CaFI trial. And we're really excited to hear from our presenters today. So I've introduced myself. We also have Professor Dawn Edge, who's the director of our EDI research unit. She's also Professor of Mental Health and Inclusivity. And if that's not enough, she's also the Chief Investigator for CaFI. We've got Reverend Paul Gray, who was a lived experience consultant on CaFI, and Lilly Huggins, who's Head of Community at GADM. Without further ado, I'm going to pass over to Professor Dawn Edge.
Oh, thank you. Thank you so much, Emma. And thank you, everyone, for being here. It's wonderful to, well, I'm going to say to see you. I can't quite see you, but I know that you're there. And it's great. Thank you so much. So why do we need CaFI? So we're going to talk about culturally appropriate or culturally informed care for psychosis. And we're going to ground that in the CaFI studies to see what that can tell us about this question. So people from minoritized, racialized background in the UK tend to have higher rates of psychosis, and this is particularly noticeable for people from sub-Saharan African and Caribbean backgrounds. So as you see there, what those numbers mean for the uninitiated is that if you're of Caribbean descent, and it's worth saying that although it talks about Caribbeans, because of the age at which people come into services, the majority of people are actually Black British. It would have been people born in the UK, but roughly 7 times more likely to be diagnosed with schizophrenia if you're of Caribbean descent, and about 4 times more likely if you're of Black African descent. And I'm saying Black African descent, but for both groups, that also includes people of mixed and multiple heritage. And although these figures were taken from 2012, we've known this for a very long time, and it's actually not changed very much over time. And alongside those higher rates of diagnosis, we also have what are called more negative care pathways. So rather than coming into mental health services by seeing the GP, people are much more likely to come through the criminal justice system. It's what CJS stands for. And in prisons, there's a finding that shows that 37%, that's more than a third of Black compared with white British prisoners, have got diagnosis of schizophrenia or delusional disorder. And the people from our communities, my communities, are 4 times more likely to be detained under the Mental Health Act, or what is people usually refer to as being sectioned, and that's the way they tend to come into services. Once in services, much more it's called coercive care, so that means more likely to be held in seclusion, higher rates of medication, often being restrained. And the outcomes tend to be less favourable, so people tend to stay longer, for example, as inpatients, and tend to be discharged on community treatment orders. In services, NICE, so that's, you will be aware, National Institute for Health and Care Excellence, they recommend culturally informed care, and they've highlighted the lack of culturally informed care for people from these backgrounds. And they also, Department of Health and Social Care, also talk about staff being culturally naive, and that's partly because cultural awareness, cultural humility, those kind of things are not generally taught in people's undergraduate training or pre-qualifying training. The lack of access to psychological therapies is an ongoing issue. We know it's an issue across the board, actually. There are long waiting lists for therapy, but people from these backgrounds are especially less likely to receive psychological therapies, and particularly family therapy. And with all of that, it's interesting that people are often labelled as hard to reach. I know that the label is being used less and less, but that's been the narrative for a long time. So here, yes, so this is what NICE says, that mental health services should really take into consideration people's race, their culture and their ethnicity in the way we develop and deliver services. And I would also say the way we evaluate those services. And they talk in particular about having culturally appropriate psychological and psychosocial treatments delivered by competent practitioners. And maybe we can pick that up later on. And this to enable provision of care to people from diverse cultural backgrounds. So what is CaFI? Well, it's an intervention that we developed by taking a standard model of family therapy, which has a strong evidence base. It's cognitive behavioral therapy based. And we took that and we worked with people with lived experience from African and Caribbean people diagnosed with psychosis and schizophrenia, and with their families, with community members, healthcare professionals, and others, including the police. And we looked at what was in the standard model and asked people what needed to change to make it something that was more culturally informed for people from sub-Saharan African and Caribbean backgrounds. And we ended up with what is 10 one-hour sessions of therapy. And it's a hybrid model. So it's got bits of cognitive behavioral therapy and some behavioral family therapy. And the difference is a lot of the stuff around behavioral family therapy is kind of to do with communication. That's a really important part of this for people from this community. The therapy is delivered by what's called a therapy dyad. So there's a lead psychological therapists, and that doesn't necessarily mean a clinical psychologist. It's somebody who's trained in family work, so that may be a nurse or a social work background, but with higher levels of skill in family work, and a co-therapist. The work we've done is, as part of developing the therapy, one of the things people told us that actually, as long as the therapy is kind of good enough almost, what matters more than the content is the way it's delivered. That means that we need to really focus on the people delivering the therapy, and particularly ensuring that they have what we've called cultural humility. So not just moving beyond cultural competence and awareness to really work with our therapists to help them to understand this. And we may be able to pick that up a little bit more later on. One of the other things that we know with people from across the board, irrespective of your ethnic background, people with serious mental illnesses like psychosis over time tend to lose contact with their social networks, their families, friends, and so on. And so we knew that there may be people who would want the therapy but might not have contact with their families. And obviously, because these are people from sub-Saharan Africa and Caribbean backgrounds, there might actually be people who are in the UK without their families, people, especially those people who might have come as a result of conflict and displacement, and so their families might still be back in Africa, for example. And so this is a model that they use. The family support member, as it has ended up being called, is a model that I read about that was being used in New Zealand with Maori communities. And what they did was they invited people who wanted the therapy to either suggest somebody to take part with them, and when they didn't have that, to recruit people, volunteers from the communities to take part as therapy partners. As part of the therapy, what we had to do is to develop a therapy manual that included telling therapists, a part of that's cultural humility, giving them the background, the historical approach to how people came to be in the UK. So we talked about the transatlantic slave trade, about which many people haven't learned in school, so we had to explain that. We talked about the difference between sub-Saharan African and Caribbean communities and the cultural differences between them, and that's all part of the therapy manual. As you'll see on the right side at the bottom here, there's an image that we developed with a fantastic graphic designer, because all the therapist manuals and other resources that we'd seen didn't have any images that actually reflected the population that we wanted to work with. And then CaFI Digital we developed later on. We developed a digital offer where we digitized all of the therapy resources and the manual so that people can work with it online. And so just a note about the cultural humility. So a lot of times people talk about cultural competence, but the difference between that and humility means moving beyond just acquiring some skills to really understanding things like the power imbalances that exist, not only in the therapy setting, but also in wider society. It means for the therapist having some lifelong commitment to learning and self-reflection, thinking about how their biography, how that turns up in therapy and how that informs their relationship with the people they're working with. And importantly, at an institutional level, understanding that there needs to be different ways of working. And part of that is acknowledging that structural inequalities, including structural and institutional racism, are real and they have an impact on people. So we did a small feasibility study in Greater Manchester with that therapy that we'd culturally adapted, and it went really well. So we found that most of the people, 24 out of the 26 family units who started therapy, completed it. And we also noticed that over half of the people needed one of these family support members to participate. And one of the really positive things was that we were able to recruit people. They stayed with the therapy. So what we did was that we recruited them. We did some screening to get their scores at the beginning. Then we delivered the therapy, and then we scored again. And then 6 months later, we followed people up, and people stayed with us for all that time, including those who did not receive therapy. So when we talk about randomization, it means that people know that there's a chance that they will not get therapy. We have to be explicit about that. But people really were committed to wanting to do some things differently, and so they stayed. So that was really important. I'm very positive about the therapy itself, particularly seeing it as being culturally relevant and wanting it to be rolled out to other people. And these are some of the benefits, just briefly, from a service user perspective: improving their symptoms, but also, really importantly, going back to work or university or volunteering. And this is really important because most of the people that we engaged with had been out of work. They'd started becoming unwell when they're in university or college, quite early on in their lives, and some of them for 30, 40 years hadn't worked. And importantly as well, from a family member's perspective, it helped them to understand what was going on for somebody when they were experiencing psychosis, and help them to be better able not only to engage with the person with psychosis, but with the services to be able to better advocate for their needs. And from the health professionals' perspective, really what I talked about with that manual, having a real understanding for the first time about the lived experience of being Black and in the UK, and getting some skills that they could use in their everyday practice. So on the basis of that, those findings, we went back to the National Institute of Health and Care, National Institute of Health and Care Research, who's funded the study, and they gave us some more money to do a randomized controlled trial. And this was designed to be a 54-month trial with family units for both Caribbean and Sub-Saharan African origin people. And that's because when we were doing CaFI, which was only with people of Caribbean descent, people were being referred or self-referring to us, so saying, why can't we have it? People from Nigeria and Ghana and other parts of Africa were saying, these issues are just the same for us. Why can't we have that? So we included Sub-Saharan Africans in the main study. We intended to recruit 400 service users and their therapy partners. That's what we mean by family units. And the aim of the study was to evaluate, to determine whether CaFI was at least as cost and clinically effective as usual care. So basically, we wanted to know whether it works and whether it didn't cost any more, or at least cost as about the same. And the study was designed to be run across the Northwest, the Midlands, London, and the South, because we wanted to understand the differences that different sites might experience. Because family therapy, despite having a really, really strong evidence base, is very poorly implemented for everybody across the piece. So we really wanted to do that process evaluation to figure out what helps and what were the barriers. And we wanted a real world approach. So generally speaking, when people do psychological therapies research, they employ a dedicated trial therapist, but we really wanted to have people working in the services delivering the therapy alongside their workload, because we really wanted some of that learning to impact the way they worked thereafter, and to see if it was real, if it could actually be delivered. And then we also wanted to see, to track people's acceptability, and looked at the extent to which the therapists stuck to the manual. And that's what fidelity means. So we were due to start at 1st of April 2020, so you all know what happened then. The world went into lockdown, and that meant that we had a very delayed start. And throughout the study, it was adversely impacted by COVID. So not only the delayed start, but obviously once we actually started the study, at that time, we were really struggling to actually even get into some of the sites, which meant that in the end, we were only able to open 3 of the 7 sites that we initially started with, that we thought we would work at. So there were lots and lots of barriers, which I'm happy to talk about in our discussion maybe. But the key one was a lack of therapist capacity. So in one of the sites, we opened and we closed within weeks because there were no psychological therapists available to deliver the therapy. In another one of the sites, which is a huge site, there were no Band 7 clinical psychologists across the whole of the trust. So that was a major issue. And we're going to, again, can talk to you about some of the work that we did to recruit people outside the NHS, which we did working with people like the Association of Family Therapists and Black and Asian Family Therapy Network, and they were brilliant. But we then came across some huge barriers about getting those people to actually work in the NHS because of bureaucracy. And with all of that, we reduced the target number from 404 to 300, but we were still struggling to recruit. And therefore, in the end, the funders, National Institute of Health and Care Research, withdrew the funding early, which meant that we closed the recruitment and randomization in December of 2023. But we continue to collect what called the outcome data. We continue to follow people up to see how they did. So this is what we found. So we recruit, in the end, we were able to recruit more than 145, but we were able to randomize 145 people, predominantly male, predominantly, so I think it says on there, mixed African Caribbean, predominantly Christian. Average age 40 and a half. And as you see, most of the people needed a family. You needed somebody who was not a family member to take part. Yeah, they were roughly split half and half into those who received therapy and those who didn't. So of the people who were randomized to receive CaFI, most of them had at least one session. We again, because of the impact of COVID, sometimes people became unwell. Because people were also international, sometimes people ended up going back home. There were quite a few challenges, but 28 people completed all 10 sessions. And the independent assessment of the fidelity to the extent to which the therapists, stuck to the manual was good. And in terms of findings, well, our primary outcomes, that's the main thing we wanted to measure. So when we did the feasibility work and we asked people, what matters most to you? What they said was, we want to reduce the risk of becoming unwell again and having to be readmitted to hospital. So that's why we focus on time to relapse, is what we call it. And we found that there was a 27% less risk of relapse in the people who received CaFI, but because the numbers were so small, it's not statistically significant, so we can't have any confidence in that finding really. It could also happen by chance. Similarly, with most of the outcome measures, there was one that was statistically significant, and that was about when we looked at one of the measures, which is looking at what we call therapeutic alliance, so the ability of therapists and service users to work together, the way they work together, and one of those which is about people's knowledge, attitudes, and practice, and that was positive. But again, it's because there's so few, it's difficult to say very much. However, from what we've seen, it suggests that with bigger numbers, there is a potential benefit in terms of reducing relapse. What we did find was that the manual was good and people stuck with it, and we had very positive qualitative interview feedback about the acceptability. And so the learning that we take from this could be really valuable for implementing not just this study, but other studies like this, and for scaling them up. And one of the really interesting things was that there's little evidence of the therapist's effect on those outcomes. And the participants said that the intervention was culturally relevant and acceptable. So some of the things that we learned, so we've talked about the COVID impacts, and I think that that's something that maybe really hasn't been factored into, or wasn't really factored into in some of the decisions about funding, for example, and the fact that the impact on this community. So many of you will have known, have seen the evidence that people from Black, Asian, and other minoritized, racialized communities were disproportionately affected by COVID. And also before that, stuff I said at the beginning about people's experiences of mental health services meant that there is quite a lot of resistance, reluctance to take part in research. And you probably saw and heard that when we look at even with the COVID pandemic and the vaccine hesitancy, they call that. So I've already mentioned about the difficulty engaging with the different sites. And for us, it feels a bit like an own goal. So we really wanted to do this real world research where the people who were delivering the therapy were regular psychological therapies workforce, rather than people who were brought in just to deliver the therapy. But we really struggled. And so that's important, because there's a whole new NHS plan for the psychological therapies workforce. And outside the NHS, there are all these people who have huge amounts of skill who can deliver therapy. We brought some of them in, but the barriers to doing so were really challenging. One of the things we also think about, so NICE guidelines recommends family therapy for people in regular contact with their families. So just have a think for that a moment what that means, not just for people from this particular community, but for people who are care leavers, people who are bereaved. You know, you might be somebody who's lost all of your family. And so unless we think differently, then there are going to be some people for whom this therapy can still be really beneficial, but they can't take part in the therapy. We also got some really valuable insights into training therapists and the feedback that they've given us about the impact that's had on them individually and also on their practice. And also we're now using CaFI Digital as a small project that we're trying to get off the ground in Jamaica, just to use that to expand people's access. But obviously we also know about the digital divide. So we know that unless we're really careful, then online therapy could actually enhance or amplify inequalities rather than reduce them. So again, that may be something we might pick up in Q&A. Okay, so this is my final slide, I think, take home. So there's a lot of rhetoric around, you know, you read policy documents and guidance, and it talks about doing research with underrepresented and underserved population. It talks about the need to bridge that research to practice policy gap. But actually, if you really want to do that in a meaningful way, then one of the things you have to do is to do real world research rather than research which is in some ways artificial. There's a lot of talk about culturally informed, individualized, holistic, needs-led care, all of these words. But again, there's not really the space to look at what that means from different kinds of perspectives. So the fact that some people don't regard things, for example, one of the key signs of psychosis is hearing voices. And not everybody sees hearing voices as being a negative thing or sees it as being a form of illness. And as I mentioned with the families, there are people who are closer to them than families for a whole host of reasons. And at the moment, those people would be excluded from the offer of therapy. I've mentioned the workforce issues. So of almost 27,000 psychologists, the majority, you'll see there, 84% are white and only 2% Black, 3% mixed and 5% Asian. So in terms of work, that means that in order to deliver culturally informed care, we're going to have to do work and making sure that everybody has some degree of, whether you call it cultural competence, I prefer cultural humility, to be able to work with diversity and difference. And one of the things that we found is that the outcome measures that we used, apart from one that we developed in the previous study, which was a knowledge about psychosis, that a lot of these measures were actually developed quite a long time ago, often in the United States, tested on white, predominantly male university students, and yet they're used not just here but globally aproblematically. Sometimes they're translated into different languages, but the extent to which some of the concepts that they embody are actually culturally relevant is something that we need to think about. And then the final point is that, you know, this kind of work takes time. It's really time intensive, and resource intensive, and so it needs patience and commitment, and it needs money.
Thanks very much, Dawn. I think we're moving on to your conversation with Paul now.
Yes, good afternoon, everyone. Yes, my name is Paul Gray, lived experienced consultant, as well as for about 20 years I actually lectured at Queen Mary's University, which is on cultural appropriateness actually. I've been very involved in research, from breaking circles of fear, some big researches over the years, and experience of being using the services as well as developing services, evaluating services. Yeah, that's a little bit about me.
Okay, that's great. So you've been part of the CaFI journey, right, since the very beginning. So can you tell us a little bit about why and why that is and how you've contributed?
Well, you invited me, I think it was back many years ago now, is it, when it first started in a grassroots organization, New Testament Church of God in Manchester. You know, you pulled resources together from the local community to do some work within the community, and I came along, gave a presentation. From there, became a signatory to CaFI and advisory on the board, as well as involved in research. Yeah, that's been my journey with the CaFI journey.
Yeah, and even co-authored one of our papers.
Co-authored, yes,
Yeah,
co-authored,
yeah.
presented,
Really
and yeah.
Yeah, really important. Okay, so what does culturally informed care mean to you?
Culturally informed care is first listening, learning, and linking. You can't serve people you don't know. You're better. I mean, an example of culturally informed services is Antenna, for instance, back in the 90s. That was in London, in Tottenham, which was a service developed by the NHS, and it was, you know, therapies who were from the community. The leaders were from the community. It was a tremendous service. But one example of a culturally informed, which isn't informed, is when I was on the ward one day, and actually it was a Jewish man who was praying, and the nurses rushed in because they thought he was going to harm himself. So culturally informed services is what listens, learns, and then links, connects people to their resource, to what supports them in their ability to move forward in their health.
Okay, so why do you think that matters? And you know, some people would say, shouldn't we just be striving for standardized care where we treat everybody the same? So tell us a bit more about why you think this matters.
It matters because how the diagnosis of mental illness is different for different people. For example, there's some diagnosis, if you don't look someone in the eyes, for instance, you might feel that the person is hyper or they're loud or whatever. But a person, when I was growing up, for instance, in my culture, to look someone in their eyes was a form of disrespect, particularly the elders. And so not understanding that, and if you're being diagnosed with a doctor who has no idea, or psychiatrist who has no idea about that background, you are more likely to be diagnosed with some form of whether it's, you know, whether mania or whatever, or because you according to them, you're not engaging, or for instance, loud when you talk. When some cultures are talking and they're excited, they might be louder. For instance, and that again might be deemed as aggressive or so they're very not understanding the person's culture can actually go against them, because as you rightfully stated, in many ways the system of mental health and the way the diagnoses are developed is from a Western ideology and philosophy, and it doesn't match cultural concept of mental well-being.
Yeah, and you know, that's a really good point. I remember having a conversation in terms of a lived experience with one of my colleagues, psychiatrist, about being followed around in the shops, and she asked me what I meant, and I said, well, this is precisely why we need something like CaFI, because I don't know any Black person who would have to ask me what that means. And some of you on here will probably remember a few years ago when there was a big to-do because Oprah Winfrey went to Milan and went into Prada, and they would not take out one of the handbags to show her because the assumption was that she would steal it. And that's our lived everyday experience. So that presumably in mental health services, without that level of understanding, might then be seen as paranoia, be telling people saying that people are following you around.
Well, just hold on that question,
Go on.
That the funny part about that's the crazy thing about all of this, is that many of the security guards are Black, and you know that's how ingrained this thing is. Similarly to some of the nurses are from Black community as well, which are service. It's not only a color thing. The very essence of the system is so corrupt. Whatever color you are, you operate the same way in many ways.
Yeah, and I think that's a really important point about how structural racism, structural inequalities, how embedded they are into structures, into systems. So this is not about an individual person being racist. This is about, you know, this kind of thing happens and nobody's picking up how it affects certain groups of people, and that level of understanding or not can contribute to the way someone formulates when you're, as a service user, you're telling psychiatrists or psychologists about your experience. If they don't really have a frame of reference that will inform the way they see it and the extent to which they see it as being something pathological or, you know, a reflection of your lived experience. So I guess one of the things you shared with me before was about something called tambourine therapy. I wonder if you want to say a little bit more about that.
Yeah, well, as I said, I think is what works for communities. So for me, the playing of the tambourine is significant, both spiritually and physically, in the sense of where it's coming from and what it does. It brings people together, but particularly the elders, young people as well, but particularly the elders, for you to hand them a tambourine, the songs, the resilience, it's all built there. It's already there for them. Their therapy is in playing, in praising God. So for me, some people like yoga, some people will do mindfulness. I don't particularly go for those kind of things, and many of people don't necessarily want to use those kind of therapies. So tambourine therapy is developed and is a design and a concept which will focus on particular people and which they understand, but it's showing what happens when they do what they do. And I think, as the quote from Suman, you know, mental health services need to be rooted in people's cultural and spiritual realities, or they risk becoming irrelevant or harmful. In London, for instance, there's an organization called Grace, and they have Keep Fit. The music, what is used, is culturally relevant to the people what are there, and the people folks will get up and start moving because they recognize the music. And so cultural therapies which are based and developed from people's perspective, listening historically, what works for people. This is for me what's important, because it works, you go deeper into it as well as keep listening.
All right. Thank you. So I know we need to move on to Lilly, but I just wondered, from what your long experience and your engagement with CaFI, what would your take-home message be for service providers and policymakers?
We know that the system isn't working. We know that it's failing people. People have died in the services. I personally know Roger Sylvester. We have had Rocky Bennett, you know, and it goes on. And we keep forgetting about these, or the policymakers. Only when a crisis comes, we go back and actually want to do something. But I guess what I want to say to the policymakers is this: learn from the past, invest in the communities that we can have mental health promotion rather than reaction. And that is a long-term vision. And there are good practices like CaFI and others which are recognizing the importance of having longevity rather than reactive short-termism.
Thank you so much. It's a great note to end on.
Yeah, thank you so much, Paul. That's really, really helpful and insightful. We're going to pass on to Lilly now. She's going to talk about advocacy, culturally informed advocacy.
Hello everyone, hi, my name's Lily. I'm from a charity called GADM, and I'm talking to you today probably about my favourite thing, which is advocacy. I'll tell you just a bit about GADM first. So we're a charity based in Greater Manchester. We deliver a range of services, but what we do is mental health and carers support services, which includes therapy, carers across Manchester, Salford. We do a range of things. What we're about at GADM is we say that we work towards equitable health, wealth and self. We want to reach communities and we want to work in partnerships. So we believe in collaboration, not competition. And we're always working hard to work in partnership and innovate the services that we've got, drawing on what we know is that our communities know the answers to a lot of the challenges that we have. We need to resource them. So I would normally do a little activity here where I talk about advocacy, because I think advocacy is a really interesting word, and it's what advocacy is. Compose a challenge. Delivering culturally appropriate advocacy. The word advocacy doesn't always translate into different languages. It can mean different things in different contexts as well. But how we define advocacy is having your views and wishes heard, protecting your rights, obtaining services that you need or resources that you need. And what an advocate does, so someone that's in the role of an advocate, is they help you express those views and wishes. They can help you plan meetings, inform you of your rights, what your options are, so you can make informed decisions, contact people on your behalf, and be a sort of independent professional within your life to sort of support you with what's going on. So I think it's important just to lay out what advocacy is before I move on to the next section, which is culturally appropriate advocacy. Advocacy, there's lots of types of advocacy, but one that's very important and pertinent to the discussion today is independent mental health advocacy. So the way it works in England and Wales is if you are detained under the Mental Health Act, under a section, you're sectioned, you're entitled to an independent mental health advocate known as an IMHA. And basically they're an additional safeguard. The purpose of their role is to uphold principles of the Mental Health Act. And we know advocacy can help address issues in mental health care. We know Black and racially marginalised people experience disproportionate coercion, as discussed by the previous speakers, and detention rates. And we know advocacy can be a good tool, but there are some challenges within advocacy. So this basically summarises some of the issues with advocacy provision that a lot of people experience when they're accessing advocacy service. So there's generally just a lack of awareness about advocacy, whether that's professionals, policymakers, people who need advocacy. There is developing but still limited understanding of what the role of an advocate is. There's big variations in commissioning across local authorities. What advocacy looks like in different areas really varies, both in terms of competency and the amount of services that are resourced. Generally, as discussed, there's a lack of resourcing going on, and that means that advocacy services have been increasing waiting lists. And I think because of this, there's a lack of person-centred approach. So, and what I mean by this specifically, because I think it's important to be specific around this term, is advocacy is most effective when you look at the whole person and everything they bring with them. But the challenge with these pressures is it becomes issue-specific and it can feel tokenistic. There's also racism in advocacy services. There's not that focus on being culturally appropriate. And there's what I call reactive statutory remit. So essentially people get advocacy too late. The way the laws are written around when you get an advocate means that at the point you get an advocate, you're already in hospital. You've already been detained under the Mental Health Act. And once you're not detained, then you lose that advocacy support. So there's some problems there within the structure of the statutory advocate role. So the solution is culturally appropriate advocacy. I think we've discussed sort of what that term could mean. I think I'd summarise it being it's person-centred, so it prioritises the cultural experiences of our advocacy partners, which is what we call our clients or our service users. It's advocacy that understands the cultural as well as religious or spiritual needs of the person and actively challenges racism and works with the person to address the outcomes that they need. It's advocacy that works with people regardless of whether they qualify for other services, that is proactive in its approach. And it's underpinned by an ongoing commitment by advocates to the individuals that deliver the service and the organisations that facilitate the service to lifelong learning, cultural humility, reflective practice and improvement. So I'll talk to you now about a little bit about our service. So we delivered the Greater Manchester Culturally Appropriate Advocacy Pilot from 18 months, which finished in March 2025. It was funded by the Department of Health and Social Care to basically look at how effective culturally appropriate advocacy is in addressing what they call racial disparities in the Mental Health Act, so the disproportionate detention of people of colour, especially Black people. And also working with the DHSE and independent evaluators to develop what we call a generalisable culturally appropriate advocacy model. So what would that look like? How could that be used in lots of different places in the UK? We delivered in partnership with African and Caribbean Mental Health Services. They're a small charity that was founded in 1989 in Moss Side, specifically to address the disproportionate number of Black young adults being detained. Our team, all of our advocates are trained in culturally appropriate advocacy and have experience providing advocacy to people in Manchester. And we also had an MDT, so we had people that were qualified advocates, social workers, youth workers, people with lived experience. And everyone that joined the team, we assessed specifically on their experience in advocating for racially marginalised people and being anti-racist in their approach, whether that is both professional or personal experience, because we know there's lots of good advocates in our communities, and assessing people always through a very narrow professional lens doesn't necessarily mean we get the right people in the role, so it's sort of broadening that out for everyone. So this is what we do. We hired a team of advocates with a track record of anti-racist work. Similar to what Dawn was saying, we wanted to take the learnings from this pilot and embed it into the system. So that it included seconded advocates that were already working in Greater Manchester. They could join the team, sort of learn and develop their practice and then go back into their advocacy services. We did some training, we had peer advocates, we did both group and one-to-one. We were in inpatient settings, visiting people on the wards and community as well. So here are the outcomes. So we worked with, over the course of 18 months, we worked with 289 people across Greater Manchester. We found that 87% of people felt that we helped them get the care they need. 65, I think it says 65, report that we reduced the risk of them being detained or re-detained under the Mental Health Act. 94% of people said that we helped them understand their rights, and 61% of people agreed that we helped them leave hospital sooner. So pretty good outcomes, especially for a pilot service of only 18 months. We're very happy in terms of this impact. Another thing we worked on with culturally appropriate advocacy is, obviously as advocates, you know, you work one-to-one with people, but we wanted to look at this systemically as well. So we did, I don't know, systemic advocacy, institutional advocacy, and we aligned it with the patient care race equality framework, which I'm sure a lot of people are familiar with. Basically, our approach was we'd build relationships with patients or the people accessing our services. Our advocacy partners then disclose, like, you know, information about their experience. We collated this into themes, asked our experts by experience and advocates to find solutions to those problems, and then we'd feed those back to GMMH every quarter. So we were like, here are the themes that we see coming up. Here are the solutions that people are proposing. And one that I'm still working on at the moment actually is around improving medicine access, as this was a consistent theme, people not being understood, many challenges in terms of appropriate medicine access. So the future of culturally appropriate advocacy. So currently there's no service is funded in Greater Manchester for culturally appropriate advocacy, though it is funded by trusts in London and Sheffield to support the delivery of the patient care race equality framework. I'd say awareness for the need for culturally appropriate advocacy or informed advocacy is increasing, but still limited. And what we also know is from our pilot, we are proving that we can support racially marginalised people to leave hospital and have their voice heard. And that's absolutely essential in terms of recovery and dignity of people accessing our mental health services. So again, it was a pilot, we're not currently delivering it, but we are currently delivering Recovery in Community in partnership with Manchester Mind. It supports people to leave mental health inpatient care and to connect to community. And as Dawn was saying, that connection to community, whatever that looks like to the individual, is absolutely essential in ensuring their recovery. Our team of culturally appropriate advocates, most of them is now working on this Recovery in Community project. We're delivering culturally appropriate care, as that's essential in terms of our delivery within that. And that's everything from me. So thank you so much for your time. Thank you for having me. And if you want to talk more, send me an email.
Thanks, Lily. So the next bit is Q&As. Very helpfully, a couple of you have sent us some questions in advance. So Dawn, this one's probably best for you. What's the main difference between CaFI and standard family therapy?
Yes, I kind of touched on this briefly in the presentation, that the main difference really isn't so much the content, although because it's a hybrid model, there are extra aspects, like there's a bigger emphasis on communication and on advocacy. But probably the biggest thing is the work that we do with the therapists around their awareness and upskilling them to be able to talk to people about race, and to be able to explore their own experiences and their own perceptions about racism, and also different models of mental health and illness. So that's probably the biggest thing, really. And that means that in our model of therapy, so usually in family intervention, family therapy, there's an element called psychoeducation, and in ours it's called shared learning. And that's because the people who co-designed the intervention wanted it to be really clear that the therapists would need to learn from the families as well as them learning from the therapists. And that brings in the whole element of cultural humility, is that the therapists enter the therapeutic space knowing that this is a shared endeavour and they've got stuff to learn as well. So that's probably the key thing, is the work with the therapists.
Thank you. And I know that we've talked about family support members. So one of the questions is, if they can take part without their family members, is it right to still class it as family therapy?
So that's a really good, is that philosophical question? Maybe it's a positive question. And that's something I think that unfortunately, because the study was ended sooner than we'd anticipated, that we weren't really able to fully explore, because we really wanted to be able to see what difference it made in terms of the outcomes, whether you took part with a family support member or with a family member, and you need the numbers to do that. We know from the feasibility study that actually, there were small numbers, so you can't say for definite, but there seemed to be a bit of a trend where people who took part with family support members actually did really well. And part of that is linked back to what Lilly was saying, is that for some people, it's as though this gave them a bit of a bridge back into community. And for some of the people that we had in the feasibility study and in this one, they started with a family support member, but at some point during the therapy, they then switched and worked with a family member. And often when they were saying at the beginning, I don't want to do this with my mum, she's got enough on her plate, it's too much. But once they started therapy, they could see the benefit. So sometimes actually it was a way of enabling people to do the deeper therapeutic work that they needed to do.
Wow. We've had another question come in. This is from Alia. What a great intervention, very needed. Are there plans to start training therapists so that they can start supporting their patients in their respective services?
Well, yeah. If the study had gone to full time and we'd been fully powered, our hope would have been that we would now have a treatment that we could go to NICE and say, this is cost and clinically effective, will you recommend it across the UK? Unfortunately, we haven't got that. But what we are doing is, so when I wrote the application, I'd made a commitment that we would make the therapy resources available to people in the NHS after this trial has ended. So we're working with Innovation Manchester at the moment to try to turn the resources and the therapy manual into an online CPD unit that other people can have. We have done, so I think Heather's on here, Heather Etzel, who was one of our CaFI therapists. Heather and I delivered a cultural humility workshop for therapists of people in SLAM, Sutherland and Maudsley NHS Trust. So again, the scope for us to work with different trusts, if they want to do work around the training element, we can come in and work with people.
I think I'm going to ask this to all three of you and probably go around in turns. We've got a lot of clinicians on the call from lots of different NHS trusts and as well as many other people from different backgrounds. But is there some top things that people can start doing ASAP to be more culturally informed in the way that they care and the practice that they do? I'll start with Lily and I'll probably work to Paul and then Dawn, if that's okay.
An interesting one. I think one thing that we really learned from this is there is no quick solution in terms of embedding culturally appropriate care. However, to start on that journey, there needs to be conversations and commitment from leadership that's consistent. There needs to be conversations about what racism is, what that looks like, how it impacts people, both your staff and the people that access your service, and start by having those conversations. If you're not familiar with the model of cultural humility, look into that. We touched on it briefly, but within a team, you cannot represent everyone. You cannot hold the knowledge of all different cultures of the world. But what you do need as a clinician is you need to be able to ask the right questions, to bring someone with you, to let them lead, to listen to them about what is important to them and trust them. I'd say the main thing for us though is those conversations need to be had. It needs to be looked at in terms of like when you're recruiting people, when you're appraising people at work, team meetings, and opening up those conversations will begin that journey, that path. So yeah, that would be my advice. Have more conversations about it, and if it's not something that's discussed within your team, within your leadership, then it needs to be.
Thank you very much. Paul, do you have an answer for that? No pressure.
Yeah, I mean, if you're a mechanic, you study vehicles and you understand the different models of vehicles. If you're involved with people and you really want to serve them efficiently and better, you need to dive into their histories and spend time in that, but then also spend time listening to people as well. I think it's fundamental that that those who are working in the area of with people do that. So it's the listening, learning, and then applying what you've learned, because it shows that you've understood and you're moving forward rather than just keep asking questions. That's what the irritation's about when we talk about cultural practices. There's constantly asking questions, but it doesn't seem to impact and bring about long-term changes. So they're listening and then learning and then linking, but knowing the histories as well, very important.
Thank you very much, Paul. And finally, Dawn.
Yeah, so I think that the line about sustainability and about leadership, I think those two are really, really key. So for those of you who've been around for a while, you'll know that in 2005, the then government launched a policy which was called Delivering Race Equality, or DRE. Paul was a DRE ambassador, and the strapline to that was Delivering Race Equality in Mental Health in 5 years. Okay, so that's 2005, and 20 years on, we're still having these conversations, because what you need is a long-term commitment, and for this to be actually embedded somewhere, because what tends to happen is there's a bit of a project. You know, Lily's talked about her pilot. We had a pilot. We did the study that the funding got pulled, and so there's some potentially really good things that never actually end up being embedded anywhere. So I think for that to be the case, because that's how things are going to change, right? So we have, in theory, Lily mentioned, we've got the Patient and Carer Race Equality Framework, and I've dropped that into the chat, the link to that. And that came out of when we did the review of the Mental Health Act. And the idea is that this framework would enable organisations to evaluate, or indeed an external body like the CQC, I'm not quite sure where they're going to go, but for somebody else to evaluate your service, or for you to self-evaluate the extent to which you were delivering culturally informed care. And it's supposed to have been rolled out across the country. It hasn't. There were 4 pilots. Greater Manchester was one of them, and yet there are lots of people in Greater Manchester who never heard of PCREF. So it's that kind of, there's that disconnect, which I mentioned in my talk, where you've got policy things, and then you've got the practice, and you've got the practitioners, and they're just not connected together. So they're great ideas, and there's some good interventions, but somehow they're not all coming together in a way that's sustainable. And I think at the heart of it is Lily's point about leadership, but also education and training. I think people ought not to be able to qualify as a social worker or a psychologist or a doctor without having done some of this work, which is looking at their own biography and how that informs the way they practice, and understanding the different lived experience that people bring into services.
Thank you very much. I think on that note, and having all of you contribute to that question, I will close up here, but there's so much more to discuss. So I think our next slide actually is Dawn's contact details and ways that you can find out about the EDI research unit and CaFI, the project, the study as well. They both have different websites there. And keep looking out for our webinars, which the next one is the end of August, and it will be about parenting and perinatal mental health. We've got loads of studies, we've got social media as well, so please do give us a follow as we try and get the word out there about some really exciting and innovative mental health interventions and studies that we've got going on. So thank you very, very much, Dawn, Lily, and Paul, and thank you for the support, Amy, and all of you for making the time today, and we hope we can continue the conversation going forward. I'll end the webinar now. Have a lovely rest of your week.
Oh, thanks everyone. Thanks Emma, thanks Amy, Paul, Lily, and thanks to all of you for being here. Really appreciate it.
Wonderful. Thank you everyone.